The Jerry Pal podcast is brought to you by Archstone Foundation, preparing society and meeting the needs of an aging population. And now, here are your hosts.
Welcome to the Jerry Pal podcast. This is Eric Wadera.
This is Alex Smith.
And Alex, we have two people in our studio today.
We have two people. We have Brook Calton, who is the director of home-based palliative care at UCSF. Welcome to the Jerry Pal podcast, Brook.
Thanks so much for having me.
And we have Grant something.
You've got this.
Grant Smith.
Are you guys brothers?
We are distant, long-lost cousins. He's from the Tennessee branch
Exactly.
of the Smith family.
Yeah.
Grant Smith, who is a palliative medicine physician at Stanford. He's on loan to Stanford from UCSF.
Do they know that?
I don't know if
That was accurate.
I hope nobody at Stanford is listening. Grant, welcome to the Jerry Pal podcast.
Thank you for having me. Super excited to be here.
So we're going to be talking about home-based palliative care. But before we get into that topic, you got a song request for Alex?
The song we're requesting today is Back Where I Come From by Kenny Chesney.
And why this song, Grant?
So Kenny grew up and was born and raised in Knoxville, Tennessee, which is also my hometown.
Great. And it's kind of like back where I was about being home-based palliative care, the topic. Yeah.
Exactly.
It all comes together. In the town where I was raised, the clock ticks and the cattle graze. Time passed with amazing grace back where I come from. You can lie on a riverbank or paint your name on a water tank or miscount all the beers you drank back where I come from. Back where I come from, where I'll be when it's said and done. I'm proud as anyone, that's where I come from. Yeah, that's great. Kenny Chesney, that's our second Kenny Chesney. First was Old Blue Chair. That was Jeff Williamson on the blood pressure control Sprint Mine. I had not heard Kenny Chesney before, but he's growing on me.
You're welcome.
Yeah, thank you.
Okay, so this is our home-based palliative care week on Jerry Pal. So we have 3 of Grant's posts that we just published on Monday, Tuesday, and Wednesday of this week on home-based palliative care. Grant also just published in January, I believe, a paper for the Journal of Palliative Medicine on home-based palliative care. It was a personal reflection. And I'm wondering, Grant, kind of taking a step back, and we'll have links to all of those things on our Jerry Pal website. Like, how did you get interested in home-based palliative care?
I was really lucky during residency actually to meet Brook and had some opportunities in residency to go do some home visits with patients who were being followed by Brook and the home-based palliative care program at UCSF. And then as a fellow, I wanted to do an elective to sort of learn more and see more. And so my first month of fellowship, I spent a month with Brook and also took some time to talk to other providers in the area about home-based palliative care to find out more about sort of what was going on in California.
Yeah, and you, for the JPM paper, it's called Home is Where the Heart Is. And you describe an experience in home-based palliative care that seemed like it was a pretty important experience to you. Do you want to describe it for our audience?
Yeah, I think one of the most powerful things about going to visit a patient in their home is how that experience can have a huge effect on you and your relationship with the patient. So I talk about in the reflection piece how walking into the patient's home really reminded me of my grandfather's makeshift garage workshop. And this patient's home had the smell, the feel, the look of my grandfather's garage workshop. And I think that just helped me be present in that experience in a different way than if I were seeing the patient in clinic. Also, seeing the context of the patient's home, it validated his decision-making process. I just could understand, you had all this collateral information about the patient that was just immediate from the smell, the look, everything going on confirmed what was most important to him. And in this case, it was about his independence, and his home looked that way. And so it was just a really powerful experience to see how a home can help could help me understand more about my patient and also help me feel more connected to my patient in a way that I just couldn't get in a clinic visit.
Yeah, and Brooke, you've been doing home-based palliative care since
2013.
2013. So quite a lot of experience in the area. How did you get interested in it?
I sort of had tossed around when I was a medical trainee a bunch of different careers in palliative care, in oncology, and in primary care. And for me, home-based palliative care is kind of a lovely blend of all of those three things. We get to care for a lot of patients who have cancer. We get to follow people longitudinally over, some number of usually months to sort of many months or even a couple years. And I get to practice specialty palliative care as well. And so for me, it sort of feels like a very natural fit. And had also had some experiences during my own residency doing home visits similar to Grant. And, what a cool way to care for people. Like totally old school, but super cool and cutting edge in a way now.
It is cutting edge. This is a relatively new addition to palliative care, this sort of idea of home-based palliative care. So you were probably 2013. That's kind of the leading edge when this was just starting. Because I still think of it as just starting. 2013 was 7 years ago now.
Yeah, I mean, I think as we all know, palliative care really started in the inpatient setting and kind of grew up there, at least from a specialty palliative care consultant perspective, and then moved into the clinics, particularly starting in oncology clinics and oncology centers. And then I think sort of a natural extension from that, we started moving into the home. And I think, now, and we'll talk some, I'm sure, about this as well, it sort of is something that just makes a lot of sense for everybody. It's a win-win for patients and families who can't get into clinic and, feel so grateful that you can see them where they are. It's a win-win for clinicians because I think there's a lot of rewards and sort of job satisfaction that comes with caring for people in their home. And then for potential payers and different payment systems that are sort of becoming even more present with value-based care, it's a win-win for insurance companies and other people who are trying to manage people's care and expense as well.
Can we get to kind of thinking about kind of when we say home-based palliative care, what do we actually mean by that? Does that look like what it looks like from an inpatient consult service? Does it look like your traditional clinic? Does it include telemedicine, or is that not home-based palliative care? Because you're not what's. And we had if people are interested, we had Michael Fracken on a while ago on our Geriatrics podcast talking about telemedicine into people's homes.
Well, maybe I can start by talking a little bit about some of the models for home-based palliative care, which I think gets a little bit at your question of what does it really look like and what are we talking about? And I'd say that there are probably four major models for how home-based palliative care is delivered. One is through home-based primary care that often would be a primary care doctor, potentially a geriatrician, or potentially a palliative care provider, but you're going into the home really to own all of the care that's going on with the patient. I think the VA is a good example of that. Their home-based primary care program, they do a lot of palliative care. And some of those programs will have access to specialty level palliative care providers. But that's sort of one model, home-based primary care that does palliative care.
That would be a primary home-based palliative care, specialty versus primary. Because the VA, when I think of the word HBPC, I always think of a home-based primary care because it's grown up in the VA. But they don't necessarily have palliative care expertise. But they're really sometimes good at doing palliative care, but they're not specialists.
That's right. They're certainly doing a lot of the work of palliative care, but aren't necessarily specialty level palliative care.
I will add that, we have a really terrific, relatively large home-based primary care program at UCSF called Care at Home, which was initially the sister program of our more traditional sort of home-based palliative care consultative model, which Grant will talk about. But many of those clinicians are palliative care boarded. the physicians and then the nurse practitioners too, for the most part, have gone through advanced certification in palliative care. So, that is, they may not be palliative care doctors, but many of them do have specialty training.
So just to say sort of a second model of home-based palliative care is sort of home health plus. I think the Sutter AIM program might be the best example of this, where it may not be a physician or a nurse practitioner, but a nurse and a social worker who might be going to the home to help support advanced care planning or goals of care conversations. The third would be a hospice-based program where hospice is sort of expanding their traditional services and providing palliative care. So they're sort of figuring out their funding source, but it's them providing palliative care at home.
I feel like that's a big rapid growth area for hospices.
For sure.
But this is different from traditional hospice.
That's right.
In patients' homes. So sometimes we draw those Venn diagrams about palliative care and hospice. Is home hospice within the Venn diagram of home-based palliative care, or is that not? Sounds like you're suggesting not.
I tend to think of them differently. I'm curious, Brooke, if you feel like that as well.
I'm not the best with Venn diagrams.
But you think of home-based palliative care and home hospice as distinct.
I mean, I think that they share a lot of the same features in terms of excellence in symptom management, excellence in communication, a team-based approach. In order to be, let's say, certified, so there's a certification for community-based palliative care through JCAHO now. In order to be certified, one of the requirements is that you offer 24/7 access to care as a home-based palliative care program. So those are some of the similarities with hospice. But obviously, or maybe not obviously, I'll say, you don't need to have a less than 6-month prognosis to be seen in home-based palliative care. Many of our patients are still seeking curative or life-prolonging therapies. And some of them are not, but some of them feel that at this point hospice is not the right fit or doesn't align with their goals of care.
Mm-hmm. So you were saying that there are some hospices that are starting their own home-based palliative care programs, and those are staffed by physicians, nurse practitioners, clinicians. Do they have is it multidisciplinary team?
I'd say there can be variability. This is just from what I learned when talking to some of the organizations in the area.
Right.
I think a good example actually is UCSF's partnership with Hospice by the Bay. And that's where Brooke was sort of serving as a physician overseeing nurse practitioners who were employed by Hospice by the Bay to go provide home-based palliative care in San Francisco. Do I have that right, Brooke?
Mm-hmm. Yeah. So we have a whole team of physicians, nurse practitioners, social workers, chaplains, who are helping to take care of people in their home. And I think one of the reasons that a hospice may decide to offer a home-based palliative care program is, number one, to expand access to people who don't otherwise have access to palliative care, and also to potentially increase their referrals to hospice and hopefully get people into hospice earlier.
Mm-hmm. So first program is a home-based primary care program that has a palliative care component in what they're doing. The second is more sort of like a bridge model, as it's known in many parts of the country where they don't have Sutter AIM, for patients who are sort of an extended home health program. And the third is these hospices creating their own home-based palliative care programs. What's the fourth?
I'd say the fourth is a specialty palliative care team that is sort of doing this work, not necessarily on their own, but as part of a large academic medical center or something like Aspire Health, where they're their own entity and they're working with patients to provide specialty level palliative care.
I'm just dancing to Eric's phone going off.
Yeah. I'm not sure the listeners could hear that, but my phone actually just went off.
And I'd say that model is also what UCSF's home-based palliative care program is. It's specialty level palliative care going to the home to deliver palliative care.
Mm-hmm. Brooke, you want to say anything more about that fourth model?
Yeah. So, that type of fourth model is we essentially have two models at UCSF. The one that I mentioned before, that's with our affiliated hospice agency, and then our model that is primarily taking care of our fee-for-service patients, which includes all of our Medicare patients for now until we hopefully have better ways to pay for it, is our other model. And again, that includes a whole team, but the services are, I would say, more limited. We are not providing 24/7 access overnight and on weekends. We can do sort of a limited amount of urgent visits, but because of the way that we're financed, we don't have as full array of services as others might.
So what are the common ways people get financed? How do these programs get supported?
There are a couple of different mechanisms. I think one that people sometimes rely on is philanthropic support or grant-based programs. Sometimes large academic medical centers will sort of buy into the importance of palliative care and help fund that through getting revenue from other sources, other fee-for-service sources. Independent provider groups sometimes do direct contracting with payers. That's like Aspire Health, Resolution Care, I believe, also sort of going to the payer and saying, let's work together to come up with a plan to pay for our service. And then I think there's some newer pilot demonstration projects that are really coming out of CMS and CMMI. So the Medicare Care Choices model, or MCCM, is helping to provide payment for hospices to do what we talked about in kind of that third model, hospice to expand their services to allow you to get fee-for-service benefits while you're getting hospice services. Another program is the direct contracting model option, where you can basically take on more risk. So it's sort of like the idea of accountable care organizations, where you might get some upfront payment or a value-based payment towards the end. And that's another mechanism. And then I think one of the newer models is the primary care first models, which are sort of just rolling out. And they have a serious illness program within that, where patients who have chronic complex needs who do not have a primary care provider can actually have their care sort of taken over by palliative care specialists to provide wraparound care. And again, it's really a risk-based model where there's a per member per month payment plus a visit fee to help reimburse. And then you do your best to try to provide really good care at the cost. So those are the models that I sort of know about.
And you mentioned JCO.
Mm-hmm.
So
it's the Joint Commission.
The Joint Commission. They actually certify home-based palliative care programs. Yeah.
They do, yeah. So, just like there's JCO for hospital palliative care programs, they now have a community-based palliative care certification that's new within the last few years, I would say 4 or 5 years. And it's available not to all of the different types of models that we've talked about, but it's available to home health and hospice agencies that are offering home-based palliative care now.
Why would I want the Joint Commission certification?
I think because it's a really fun process to go through, probably.
It does not sound fun.
I think from a global perspective, it's important that we're trying to standardize the work that we do and make sure that there's some quality assurance to the care that we're providing. From a practical perspective, if these programs are going to be contracting with insurance companies. So for example, the program that I mentioned with our local hospice agency, Hospice by the Bay, that program is called By the Bay Health. We're contracted with 3 payers who pay us a certain amount of money per month to take care of each of their patients. And one of those payers, at least out of the 3, is basically requiring that they're only going to contract with home-based palliative care programs that have the JCO certification.
Uh-huh. Eric's
My
got the
phone.
phones
I'm
going
trying to turn
crazy.
my phone
so
off.
We got
popular.
Siri's listening. She's commenting. Siri, do you have a question
Siri's very
for us?
excited about home-based palliative care.
She's yelling, JCO, JCO.
It's my phone doesn't ring until I start a podcast.
right. I think the standardization, this is really important that we are held to the same standards as other important clinical services. And Grant, you mentioned Aspire Health a couple of times. I wonder if you could say a little bit more about what that is and how it came into being.
Is there a connection here?
So Aspire Health is a home-based palliative care company. And the connection is my brother helped to start that and was the CEO of that company for a while. So they were sending providers to homes to provide direct palliative care, providing 24/7 telephone assistance.
And this is a for-profit company. How did it do?
It did well.
Well, like, is there any quantification on well?
I don't have any numbers for you, but I would say that they grew quite quickly and serve many patients.
Yeah. In a particular geographic region of the country?
They're actually all over the country. So I forget how many cities, but I believe it was somewhere around over 50 cities.
Are they the largest provider of home-based palliative care in the nation?
I believe they are.
I believe they are.
I believe they are.
And it also shows, because of their somewhat rapid growth, would you say? Would that be fair? That there is a tremendous market for this, right?
I think what made them very successful was their ability to create these contracts, to figure out how to work with payers, to do a shared savings model, and to figure out how it could be a win for everyone, including patients and families.
Right. Now, Brooke, you're going to say?
I was just going to make a comment about that because I think it's something that, when you think about scalability of these programs is really important, which is that you kind of got to be big enough. It's really challenging to be a small home-based palliative care program, of which many, many of the programs throughout the country are right now, because hitting that sweet spot with staffing and how you staff is a challenge. The other thing I'll say is that if you don't have enough contracts with payers, like Grant was talking about with Aspire, you need some diversity of the people that you're seeing. So as an example, if you only have one contract with one payer who they're all, 40-year-olds with metastatic cancer, unfortunately, as an example, those are very, very expensive people to take care of. Whereas if you do have a contract with a Medicare Advantage plan, as an example, some of those people, maybe in their 80s and they have dementia, but they're stable and doing well at home, like they're going to require a lot less resources and care. And so having sort of a big enough group of people to take care of and a big enough group of staff that can sort of divide and conquer, I think it's really key for the success of these programs.
I'll just highlight that in interviewing a few of the programs around the Bay Area, Northern California, those themes were very strong, sort of finding the right patients for the fit of the program and what the program would be able to provide in terms of resources was a real challenge, in addition to figuring out sort of how to provide the financial resources to pay for the program.
Mm-hmm. Is there a best staffing model? Like, we think about hospice, there's clearly defined roles. You have to have supervising physician, you have to have nurses, you have to have social workers, you have to have chaplains, you have to have some sort of, I think, volunteer program, et cetera. Mm-hmm. How about for home-based palliative care?
I think the answer is it doesn't, and it also does depend. So, I think in terms of like holding up what we believe to be true in palliative care, having an interprofessional team model is important. That's also important for things like JCAHO certification, not to mention that just one more time. And at the same time, I think the sort of amount of each of those disciplines and how you take care of people is really going to vary based on where you're practicing, people's access to other medical care or not, where they live, how far the drive times are between places, as well as things like the types of people that you're caring for. So as an example, one of the payers that we contract with is a managed Medi-Cal plan. And so we take care of the managed Medi-Cal, which, for people outside of California is, a Medicaid plan. And those patients and families have very different needs than our patients that we're caring for that have a commercial plan, and a lot more social needs, a lot more concerns around sometimes drug abuse and that sort of thing. And so bulking up the social work support for those patients is really important. So I think part of it is, your patients and your payer mix as well.
I'll just add to what Brooke was saying that just from looking at the research studies on home-based palliative care, looking at that Cochrane review that sort of looked at all the RCTs and multiple controlled trials, a common theme of team composition at least was physician, nurse, or nurse practitioner who was also often serving as a nurse case manager in social work. Those seem to be the three entities that were just present in almost all of those RCTs that have positive outcomes, and then having access to sort of pull in as needed chaplaincy, bereavement services, et cetera. So just from, I think, what the data is telling us is that you do need multiple and an interdisciplinary team to make it work.
And then what does the actual home visit look like, let's say in comparison to a normal palliative care clinic visit? Is there any difference?
Yeah. I mean, I think so. I mean, we're in people's homes, so that's the first difference.
Okay, that's a difference.
That's a difference. I think that the visits tend to be longer because there's like more of the like you go in, you know, you got to find a place to sit down, you got to pet the dog, you know, you often will get offered, you know, water or an orange or tea, those sorts of things. You know, you got to set up your computer so that you can chart. So those things do take some time.
And I can imagine one of the first things you're doing is also assessing for safety when you're going into these new homes too.
Right. Like if the dog's going to bite you or not.
Yeah.
Yeah.
Guns, dogs.
Yeah. So, I mean, that is a very practical, important consideration of doing home visits. And, you know, if you want me to, we can go into some of those specifics too, but safety is certainly key. And then, you know, some of the visits will be just with one clinician. Some will be with multiple clinicians, like a joint visit. We also are using, Alex, to your question about, you know, telehealth and, you know, is that part of this? We are using telehealth in really cool ways, including, you know, sending one clinician to the home and then having one clinician telehealth in, so that both clinicians are not having to drive, you know, 25, 30 minutes. And that's in San Francisco. So if you're looking outside of San Francisco, 7x7, people are driving much, much further. So that saves some time and cost there. And then I think we're able to do more stuff. So you can do a more thorough med review because all the medicines, the bags of medicines potentially are there for you to review. You're able to get a sense of like what it's really like to get in and out and around someone's house and what durable medical equipment they have, and is it working, and do they have their oxygen on connected to their concentrator or not? So you're getting a sense for those things. I think, you know, the other really special thing about home visits that's different than clinics sometimes is that you are also getting a sense of what caregiving is like in a very different way. Like who's around, what are they doing, as well as, you know, interesting opportunities and really important opportunities to sometimes talk with the caregiver one-on-one in a way that you may not get the opportunity to in a clinic visit when it's like, here you are, and then you're leaving. But, you know, one of the things I love to do most when I do a home visit is, you know, if you have two clinicians, you know, have one clinician stay with the patient and then say to the caregiver, hey, could I take a look upstairs, and like go upstairs? And, you know, that's when like real talk happens. You know, you're able to provide some additional caregiver support. You're able to really understand what's going on, and they can ask some of the really hard questions that they may not feel comfortable talking about in front of their loved one.
I really like one of Brooke's tricks is would you mind walking me to my car?
Yeah.
A lot happens in that walk.
Yeah.
So last week we had David Rubin on talking about population-based health for geriatrics and for palliative care. And he described this, the pyramid, where you have like the sickest at the top and the healthiest on the bottom, and how we should tailor kind of our interventions to the needs of the different populations. When we think about palliative care clinics, home-based primary care, all these different iterations, like where does it fall? Do you need both? If I'm an academic center, do I need both a clinic and a home-based palliative care service and a telemedicine service and an inpatient service? Like how should we think about this? And where does it fall on these pyramids?
I think it's quite, because that's a really hard question to answer. And I think it's probably going to depend a lot on who you ask. It's great to see people at home. And I think if that was the one thing that you could do and you could figure out a way to finance that, then like do that. That's awesome. Like, because it's the most sort of wraparound comprehensive palliative care service that we have. And, you know, at the same time, we should also be cautious with our resources, and we don't all have, 300 contracts with different payers. And so
the economies of scale, because it's not just that, let's say the clinic visits, if they're the same amount of time, you still have to drive to the person's home. And then
you got to park.
You got to park, which is in San Francisco, it takes another hour.
Right.
So scalability is a big issue, right, for home-based palliative care?
I agree. I think scalability is really a crucial issue. And I might just add to what Brooke said that, to answer your initial question, if I'm a patient and family, in my mind, the most ideal thing would be you interact with sort of one team, and that team has the flexibility to figure out what's the right touch at the right time. Are you able to come to clinic? That might be the most economical thing for the team. But at some point, when do we start leveraging telehealth, telephone visits? And who are the patients who really need a clinician to come into their home? So it's not a perfect answer, but I think the ideal situation is that health systems, which may take unique collaborations and breaking down some barriers that we haven't done before, like academic centers collaborating with community partners, collaborating with hospices, collaborating with payers to help figure this out, might be part of the solution. But to have a team that's flexible enough to really, as you described, provide the right care, the right time for the right people is sort of the golden egg we're all chasing after. So I'm not sure how to get there, but I do think that there is a vision, and some of these, having these components is at least a good start to work on that.
I'm just thinking about the going into patients' homes and just how revelatory, that has been in my previous clinical experiences. I wonder, do you have any stories about that are, appropriately anonymized for our podcast about, oh, wow, that's what's going on at home when you walk into a patient's home?
While we're thinking about that, I do think one thing that is, there is a magic to going into the house. And I talk a little bit about this in one of the reflection pieces, that it's just so different being in someone else's space, and that the way you interact and the way I think they're able to speak to you and receive it is so different. Mm-hmm. It's hard for me to figure out exactly what it is about that, but there is something about being in their space on their turf where they sort of hold a little bit more of that power differential that is very reversed when they're coming into your clinic, your space. So I just say that to add to what Brooke has already said about, what makes the home-based visit different than a clinic visit, or maybe even different than a telehealth visit, is the physical space.
Yeah.
Yeah, I mean, I'm not sure I have a perfectly, specific example, but I think, one of the biggest sort of oh wow moments that I frequently have going into someone's home is that you can only get so much information from a phone call or a clinic visit with how someone is really functioning at home. Like, we have all these questions that we ask, like, how do you spend your days? And can you bathe yourself? And that sort of thing. And at the same time, people are choosing to tell you on the phone sort of what they choose to tell you. And I think in general, when people go into their, doctor's office, their team's office, they're choosing how they present themselves. And a lot of the times, particularly if it's a patient who, might be wanting more treatment for their cancer, they're opting to present themselves as well as possible. Mm-hmm. When they walk into the cancer center to see their oncologist and their palliative care team. And I think that's one of the most elucidating things is when you go into people's home and you realize, like, oh, every time I see them, they're in bed.
Yeah. I was just thinking about when you go in, and I can think of some joint visits where the side table to the bed has the drink bottle, last night's dinner, the remote control, their computer, their meds. And you're like, I think they may not leave their bed very much because everything is right here.
Yep.
Mm-hmm.
And it's that where you may not have gotten that picture as clearly as you do when you see it when you're in the home.
Yeah. My last question for you, Brooke, is let's say I'm starting as a clinician in a home-based palliative care program. Like, looking back in your career doing this, are there like 2 or 3 top lessons learned? Like, I wish I knew this when I started, or a couple things that you just always pay attention for when you're going into people's homes?
Yeah, actually, one thing that we haven't touched on a lot yet and I think is a struggle. I see it in the teams that I work with, and I know has been a struggle for me sometimes, in the past, particularly when I was starting out, was, we're going into the most impossible situations, right? Like you're taking care of the sickest people. You're seeing people right after they leave the hospital. They may really, in some cases, need, more support with hospice, but they're not willing to have hospice care, and you're trying to take care of them through the services that you're able to offer. And people's lives are messy, and people's goals of care can be really messy also. And I think that can be really challenging as a home-based palliative care clinician, because we like things to be tidy, and they're not, particularly when you're able to witness it in people's homes often. So I think that's one of the things, sort of, if I was to talk to sort of someone who is just starting this work, is like, we can't fix everything. We can do what we can do, and it's also not our story. So, one of the things that one of my colleagues, Bridget Sumser, who's been on the podcast before too, I know, talks about is like, it's not our story, it's their story. And so it may not be how I think things should be, or their goals may not be exactly what I think would be best for them, or that are, even realistic or attainable, but it's their story, it's not mine. And I think that makes this work more sustainable over time, to remember that we're going to do what we can to support you within our power and the limits of everything else that's going on with our services and in your own life.
As a mentee of Brooks and a new attending, those lessons that she has taught me have been extremely valuable, and to have learned self-compassion from her has been a real gift. So thank you, Brooke.
Well, are there other things you think our audience should know, or should we do a little bit more of that song?
Is there anything else? So we cover enough? That's good.
I just want to put a plug
Yeah.
for, I think it's also very easy to feel alone sometimes doing this work, because it's different. Like when I go work in the hospital, and then I see all these people that I know, and you have resources at your fingertips, quickly. And so it's very different. And it can be very isolating to do home-based palliative care sometimes. And because these programs are so new, there's lots of opportunities for everybody to get more education about how to do this work. And so just wanted to put a plug in for things like CAPSI.
And CAPSI has a wonderful, it's called Palliative Care in the Home, a guide to program design, that we'll have a link to on our Jerry Pal website.
Mm-hmm. Yep. So that's a great resource, and there's a PDF that you can download. They also have some other modules that are specific in terms of sort of how to build these programs, and then obviously all the great symptom management, communication modules that they have. And then also just a plug for the California Healthcare Foundation, who's been very, very supportive in this space and has also developed a number of resources, both for program developers and then practicing clinicians to help support you.
Yeah, it's great. It's important to have some community here, because as you say, when I'm doing consults in the hospital, I'm with this team all day. We're together all the time. We have our support network right there, one of our support networks. Whereas when you're going out to people's homes, often solo, it's a completely different sort of setup. Yeah.
Yeah, and it's totally possible to build that community, but it absolutely takes intention,
Well, Brooke and Grant, thank you very much for joining us today. How about we do a little bit more of that melody?
Join in wherever you want. We learned in Sunday school who made the sunshine through. I know who made the moon shine too, back where I come from. Blue eyes on a Saturday night, tan legs in the broad daylight. TVs, they were black and white, back where I come from. Back where I come from, where I'll be when it's said and done. I'm proud as anyone, that's where I come from.
Woo! Woo!
All right.
Taking me back home.
Tennessee.
And with that, a very big thank you again for joining us.
Thank you.
Thank you for
Brooke.
having
Yeah,
us.
this
Oh
was
my
fun.
gosh, thank you.
Thank
Really
you.
And
appreciate
to
it.
all of our listeners, thank you for supporting Jerry Powell.
Archstone Foundation, thank you for supporting Jerry Powell.
And we are going to actually try one new thing too coming forward, moving forward from here, is we're going to be using our number 929 Jerry Powell. That's 929 Jerry Powell, where you can actually submit questions for us or just letters, something we talked about in a past podcast. And we'll be talking about kind of our future podcast too. So you can submit questions. We'll be doing that through our Facebook and Twitter sites too, through that 929 Jerry Powell number.
And what podcast do we have coming up that people might call in with questions about?
That's a great question, Alex. Who I gotta while I think about that for a
I'm pretty
second.
sure we're doing our next podcast is about what is a medication error according to patients, right?
Yeah.
With Mike Steinman and Francesca Nicasia.
Yeah.
And
So
right?
medications, all about medication, deprescribing medication errors. So if you have questions for Mike Steinman and
Francesca.
929 Jerry Powell, and a very big thank you to Damon Anderson Green, who actually emailed Alex and me with that suggestion to add this to our podcast.
Great idea. We love hearing from listeners. Thank you.
Goodbye, everybody.
Bye, folks.